We'll take the first part of the BCSC book here and talk about it, go through it. There's a lot of information here. I'm going to try not to get bogged down in the details. You all have the reading material. You're all, bright people and able to memorize the stuff you have to memorize. So there's really no point in a lecture and going through that. But I'd like to sort of keep it at a moderate to high level, so we get the lay of the land with respect to glaucoma, especially for the residents and learners here involved. Okay, so we'll start with chapter one. And in chapter one, really what we're talking about is defining the parameters of what is glaucoma. Is glaucoma a disease? Well, we define glaucoma as a progressive optic neuropathy, all right? So it's the most common disease of the optic nerve, or constellation of diseases of the optic nerve. There are lots of different optic neuropathies, some associated with inflammation and neoplastic and all kinds of reasons why people can have an optic nerve that withers away, but the most common are this constellation of entities that we call glaucoma. So when the optic nerve goes, we have this progressive loss of retinal ganglion cells and their axons that results in this characteristic optic disc cupping. So this characteristic optic disc cupping that we see where you lose the retinal nerve fiber layer as it dives into the optic nerve. And you can kind of see here where the laser pointer is, that's the edge. And I can see these vessels, see how that vessel takes a little bend there? That's the tell. So that's the edge of the cup. And of course, the edge of the nerve is here. And then you have some peripapillary atrophy, a little bit of peripapillary atrophy right here. So this is the cup nerve. The other thing we often see in glaucoma is that differentiates it from other optic neuropathies is the preserved rim. Where you have preserved rim, it's still pink and healthy looking. It's not atrophic or pallorous like in some other optic neuropathies. And often you can see the pores of the lamina curvosa here. So we'll see this in other slides as well, but you can see the individual little pores there where the axons are lost, but you still have the superstructure of the lamina curvosa. All right, so there are lots of different ways that people get to a glaucoma. It's not a single disease. There's lots of different conditions in the eye that can lead to this characteristic loss of retinal ganglion cells. So that's the point. The intraocular pressure is related to glaucoma, right? That's kind of what we can say is related to glaucoma. Intraocular pressure is not synonymous with glaucoma. So a lot of the public, the lay public, have this idea that elevated IOP equals glaucoma, normal IOP equals no glaucoma. And in fact, we know that that is not true. So IOP should really be thought of as a risk factor, just like hypertension is a risk factor for cardiovascular disease. Elevated IOP is not required for glaucoma. About 40 to 50% of all people with glaucoma have an intraocular pressure that always measures in the statistically normal range from 10 to 21. So having a normal intraocular pressure is not enough to disqualify a person from having glaucoma. Similarly, having an elevated intraocular pressure does not necessarily mean that a person has glaucoma. It is just a risk factor. However, from all the studies we've ever done over the decades of glaucoma treatment, we recognize that lowering the intraocular pressure is the only proven treatment, right? So we've tried all kinds of other things. We've tried neuroprotective agents and all sorts of things, but really lowering the intraocular pressure is the only thing that we know makes a difference. That said, unfortunately, some eyes, even with low pressures, can still progress. And these can be the toughest of the tough, the ones with a pressure of 10 or 11 at the low end of normal, who are still getting worse. There I see Dr. Petros asks, how do you make a diagnosis of mild glaucoma in a myopic patient? Oh gosh, it's a simple one sentence answer. It's not, it's actually very difficult. And at a lot of the time in those patients, Dr. Petros, what will tell me is myopia, although you can have myopic macular degeneration. Myopic degeneration of the retinal nerve fiber layer is not something that typically happens, but degeneration of the retinal nerve fiber layer in the presence of myopia suggests strongly the presence of glaucoma. So you can have a normal pressure and myopia and a progressive characteristic loss of the retinal nerve fiber layer over time, or cupping over time, that helps you make the diagnosis. So unfortunately, it's serial examinations of the same patient with good documentation of your examination that helps make that diagnosis. Ocular hypertension, I sort of already talked about, it refers to elevated IOP without glaucoma damage. And of course, many eyes with ocular hypertension never develop glaucoma. When we talk about glaucoma, again, it's not a single disease. There's a lot of different pathways to get there. It's the common final endpoint, unfortunately. But we generally categorize them into open angles and closed angles. The open angles, the trabecular meshwork is unobstructed on gonioscopy. That's how we define it. So you have to do gonioscopy to make this differentiation. There are primary open angle glaucomas, including POAG, the most common type here in the US, but less common in other parts of the world. Normal tension glaucoma, very common among Japanese patients, for example, juvenile open angle glaucoma, which has a genetic basis. And then there are secondary open-angle glaucomas, and we'll talk about some of those. In the angle closure category, the trabecular meshwork is obstructed by the peripheral iris on gonioscopy. There's primary angle closure glaucoma, which occurs along a spectrum from primary angle closure suspect to primary angle closure to primary angle closure glaucoma, and we'll talk about that in a bit. There's acute angle closure crisis, where a patient comes in with suddenly a very high pressure and a lot of pain in the eye. And then there's this plateau iris syndrome and configuration, which we'll touch on briefly. And then finally, there are secondary causes of angle closure glaucoma, either something pulling the peripheral iris up into the angle or something pushing the peripheral iris from behind up into the angle, and we'll talk about that. So this diagram just illustrates this point about open angle versus angle closure. An open angle situation, the normal situation is that we have fluid that's produced by the ciliary epithelium in the posterior chamber. It circulates, the aqueous circulates through the center of the pupil into the anterior chamber, where it finds its way to the trabecular meshwork. And in patients with open angle glaucomas, there's a failure of the trabecular meshwork. So the amount of pressure in the eye goes up in order to push the aqueous through the trabecular meshwork. And what happens? In patients with angle closure, generally speaking, the anterior segment of the eye is relatively small compared to the rest of the eye and compared to the lens. And fluid has a difficult time making it through that valve in the center of the eye called the pupil, and instead gets trapped in the posterior chamber, causing pupillary block and causing the peripheral iris to billow forward toward the angle and can begin to obstruct it. So when we look in with gonioscopy, we see this peripheral iris rolled forward, but we don't see the angle structures. So the angle is obstructed by either the iris directly or by repetitive trauma from the iris touching the trabecular meshwork. In the most common type of open angle glaucoma, primary open angle glaucoma, it's not exactly, but sort of a diagnosis of exclusion. You have to look for other things that can cause an open angle glaucoma. So you look for secondary causes, and we'll talk about some of them, like pigmentary glaucoma and pseudoexfoliation, which is very common here in Pittsburgh. In normal tension glaucoma, the IOP, as we said, is statistically normal, so between 10 and 21, and yet the patient to have progressive optic neuropathy. And this is the entity that we really have to be careful and ensure that they don't have some central visual pathway cause or a non-glaucomatous optic neuropathy from a meningioma or something like that. You really have to have your antenna up. And then in juvenile open angle glaucoma, it looks a lot like primary open angle glaucoma. It tends to be more aggressive earlier in life, and these patients are usually diagnosed in their third or fourth decade. This is a congenital anomaly. The eyes look pretty normal, and yet they have very early failure of the trabecular meshwork. And some of these are associated with identified gene abnormalities like the myocilin gene, for example. So lots of secondary open angle glaucomas, right? So we can't just call everyone a POAG. And even here in Pittsburgh, it's very common for me to have patients referred to me from my colleagues, either in the university or in the wider ophthalmology world, with the diagnosis of POAG, because that is what's common. And yet they have some secondary open angle glaucoma. When we examine them, we can identify that they've got pseudoexfoliation or pigmentary dispersion, or maybe they've got angle recession suggesting previous trauma. They've got a history of uveitis. They have some posterior synechia that suggests previous episodes of iridocyclitis, or they have a history of steroid use that's caused their pressure to become elevated for other diseases, rheumatologic diseases and things like that. You can have a secondary open angle glaucoma associated with bleeding in the eye, either from an acute hypema where the RBCs actually clog the meshwork. In hemolytic glaucoma, you've got macrophages that are gobbling up those RBCs as the hypema clears, the meshwork, the old shells of the RBCs that are causing. You can have tumors that lyse within the eye and cause damage to the trabecular meshwork. Viruses can do this very commonly, HSV. So if I see a patient with an acutely high IOP, open angles, some corneal endothelial edema, I'll look on gonioscopy, and sometimes you'll see small KP, either stellate or even larger KP approaching the angle, and that's pretty common in HSV trabeculitis. Lens-related, lens particle from retained lens material, either after trauma or after surgery, phagolytic, when you have a hypermature cataract that's beginning to leak lens material through the capsule, and macrophages are gobbling that up and clogging the meshwork. and then phacoantigenic glaucomas. The Schwartz syndrome is photoreceptor outer layers after a retinal detachment, usually in the fairly acute phase, meaning the first couple of days or weeks after a retinal detachment. A lot of our patients get these anti-VEGF injections for wet macular degeneration and other diseases, and we can start to see after repetitive injections intraocular pressure elevation. And then finally, elevated episcleral venous pressure, something in the orbit or a congenital anomaly of the vessels like a Serge-Weber syndrome. All right, so then the high-level overview of primary angle closure. I mentioned there's a spectrum for primary suspect, which is defined as 180 degrees of apposition without elevation of the intraocular pressure, without PAS formation, and without optic neuropathy. So this is what we used to call anatomic narrow angles. Primary angle closure still has the same apposition, but we either see the formation of PAS, suggesting some structural abnormality now of the trabecular meshwork, or IOP elevation, suggesting a functional abnormality. So this is a step beyond simple narrow angles, but there's no optic neuropathy. And then primary angle closure glaucoma is all of the above with an optic neuropathy that's measurable. And it's important to have the terminology because it helps us communicate with each other, and it helps, at least for me, it helps me think about what needs to be done for this patient. So a PACS, a primary angle closure suspect, that might be in a younger patient, it might be sufficient to just do an iridotomy. In an older patient, just do cataract surgery, and that will relieve the issue. But as soon as they step along to primary angle closure, I really want to maximally open that angle. So if they're phakic, I usually will go ahead and do cataract surgery for those patients. If they have any glaucoma, then cataract surgery alone might not be enough, and they might need a glaucoma procedure as well, like to treat the glaucoma optimally. And then again, I mentioned earlier that acute angle closure crisis. So this is the situation where the patient comes in urgently with usually several hours of increasing IOP, which is manifest to them as worsening vision, colored halos around points of light, a lot of pain and nausea associated with the pain, and often they're even retching and very uncomfortable. And these primary angle closures are very common among Asian populations, especially Chinese. So the secondary angle glaucoma, angle closure glaucomas rather, there's a whole host here. And generally speaking, they can be separated into pupillary blocks. So something is blocking that valve we talked about of the pupil that allows the fluid to move from the posterior chamber. The lens, so if it's a normal size lens in a smallish eye, that's primary angle closure. The big lens in a normal sized eye, meaning usually a mature cataract, then we call that phacomorphic glaucoma. Ectopia lentis, so you have a round lens to causing pupil block, and there's a lot of causes of ectopia lentis. Pseudophakia, especially ACIOLs, any patient with an anterior chamber intraocular lens needs to have an iridectomy to prevent the possibility of pseudophakic pupillary block. And then zonular insufficiency from trauma, from uveitis, and in our population from pseudoexfoliation is relatively common. So the zonule becomes lax, and the lens can migrate forward and block the posterior chamber lens can migrate forward and block the pupil. Vitreous can block the pupil in the case of aphakia from usually congenital cataracts in our patients, and posterior synechia to the lens from previous uveitis can cause pupillary block mechanisms. We generally categorize into anterior pulling mechanisms or posterior pushing mechanisms. So in neovascular glaucoma, you form a fibrovascular membrane on the surface of the iris, which pulls the peripheral iris up into the angle, blocking it. Ice syndromes, similar. There's no abnormal vasculature. So those are the iridocorneal endothelial. Posterior polymorphous membrane dystrophy is usually bilateral, but otherwise looks a lot like ice syndrome, and it's an endothelium that causes angle closure via pulling mechanism. And then, of course, PAS, progressive PAS formation, uveitis. And then from behind, anything that expands the posterior segment, meaning behind the ciliary processes, or result in angle closure glaucoma. So an expansion of the uveal space and uveal effusion, ciliary body cysts or iris cysts that expand the posterior segment, persistent fetal vasculature, ROP, and then malignant glaucoma, which is patients who've had surgery in the past. I see Dr. Idosa asks, for anti-VEGF related glaucoma, is there an effect other Is there a mechanism other than the volume effect? So yes, it's not completely elucidated. At least some of the effect in patients who receive many Avastin injections is that the Avastin syringes historically have been lubricated with silicone oil, just like the silicone oil we use in vitreoretinal surgery. And over time, the accumulative effect of that silicone that becomes engulfed in by macrophages and eventually can find its way to the meshwork has been shown to elevate the IOP. So that's one hypothesis. There may also be some effect of the anti-VEGF fragments themselves making their way into the trabecular meshwork and causing some change in the function of the trabeculocytes. So we don't actually think it's the volume, acutely it's the volume effect, right? Because you put 0.1 cc's or even 0.05 cc's in an eye that already maybe is on the verge of intraocular pressure elevation, and that can be enough to acutely raise the IOP. However, if I had an anti-VEGF injection into my eye right now, I would expect my pressure to go to the 40 or higher for a few minutes, and then my trabecular meshwork would regulate that and the pressure would come back down. That's why patients often have transient visual obscuration after the injection from the acutely high IOP. But usually for normal people, that resolves within 5 to 10 minutes. With glaucoma, it can persist because the meshwork's already shut down. But really, we're talking about the anti-VEGF injections chronically over time causing a premature failure of the trabecular meshwork. It's a great question. Okay, so here's the point. It's really important to determine the underlying cause of secondary open or closed angle glaucoma. Right? So it's not enough. It may be enough in the short term. It may be enough tonight in the middle of the night to administer medications to lower the pressure, right, and get the patient out of the frying pan. However, it's not enough for the long-term management of these folks, and eventually, whatever it is that caused the pressure to elevate will reoccur, and they'll continue to have difficulty. So there may be more than one mechanism at work, and we have to sort out what the mechanisms are. Glaucoma is the leading cause of irreversible blindness in the world. About 80 million people worldwide, 11 million with bilateral blindness, and about 80, and we do have an aging population worldwide, at least in the global north. So this is just a bigger and bigger problem. The risk factors are higher IOP, lower ocular perfusion pressure. There's no real way for us to measure that, but we can calculate it based on the things we can measure: older age, thinner central cornea, high myopia, and then genetic susceptibility. Yeah. Primary angle closure glaucoma is variable, but in certain populations or studies have shown that Inuit, for example, have the highest rate of primary angle closure in the world, followed by East Asian and then African populations more than European population. Populations. Female sex is a little bit more predominant than male. Hyperopia is a recognized risk factor in genetic susceptibility. This is a big chart that we're not going to go through, but suffice to say there are genes associated with a lot of these glaucomas, especially the less common, the POAG. There's all kinds of genes, and it's a very complex inheritance, but a lot of these have autosomal dominant. And I certainly have families with Axenfeld-Rieger, and patients or members of their family because it's an autosomal. Then patients for gene testing if we think it's going to be useful for the management of help, unless you have somebody who's relatively unaffected and they're thinking about family planning, then maybe it's useful to know if they really have it. So chapter 2, aqueous humor production. All right, so this, I think we can do this pretty quickly. 2 to 3 microliters per minute is the number that you have to remember. That's how much that we make under normal circumstances. The total volume, the anterior and posterior chambers in a phakic patient is between 200 and 300 microliters, which means that every 100 minutes, every hour and a half or so, we're turning over the complete volume of our aqueous. Pseudophakic patient, that volume's a little bit greater, so maybe it's every 2 hours we're turning over the total volume of our aqueous. There are approximately 80 ciliary processes supplied by the major arterial circle of the iris, so ischemia of the eye can result in hypoperfusion for sure. Aqueous is produced by active secretion from this double epithelial layer in the ciliary epithelium, by ultrafiltration and by simple diffusion, but mostly it's active secretion. So it's an active process. It's not just a filtration product of blood. Compared with the plasma, you have higher hydrogen and chloride ion concentration. There's more ascorbate, so ascorbic acid, lower bicarb, and it's nearly protein-free, although there is a little bit of albumin found in the aqueous. In patients with disruptions of the blood-aqueous barrier, this goes off the rails, and the concentration of the aqueous is more like the serum. So a lot more protein, clotting factors, and so on. Other components, lots of things: enzymes, growth factors, prostaglandin, and cyclic AMP, high hyaluronic acid, and catecholamines. So this is that double layer of epithelium I was talking about. There's a non-pigmented layer that faces the posterior chamber where the aqueous is secreted, and then there's the pigmented layer. The pigmented layer is what takes up energy in cyclodestructive procedures, for example. So the outflow is pressure dependent through the trabecular meshwork, and the trabecular meshwork has three layers: the uveal layer, the corneal scleral layer, and the juxtacanalicular layer. The juxtacanalicular is, according to the test, the site of major resistance of aqueous outflow. TM cells are phagocytic. There's 200,000 to 300,000 trabeculocytes per eye, and they are actively transporting fluid out of the anterior chamber. So this also is not just a passive process. It's some passive component. Schlemm's canal is endothelial lined with about a 300 micron diameter. So when we do procedures where we cannulate Schlemm's canal, those devices, for example, the Hydrus Glaucoma stent, 300 microns in diameter, just fits inside the canal and really stents it open. The aqueous goes from Schlemm's canal into the collector channels, and then onward to aqueous veins and so on. And trabecular outflow is dynamic. It's not a constant rate all day and all night long, just as aqueous production is not either. So it's an equation that has to be balanced with a lot of variables. And then uveoscleral outflow. Uveoscleral outflow is pressure independent. Aqueous passes into the interstitial spaces of the ciliary muscle bundles and may pass through the intact sclera into vortex veins, ciliary lymphatics, and so on. And I see a question here from Dr. Tawadros. Patients of Asian descent are mostly myopic, but the prevalence of ACG is higher. Is there any particular reason? Well, I think it's, I don't know the answer. Maybe someone else knows this answer, because my relative population of Asian patients is lower. It almost certainly has to do with axial versus refractive myopia. So eyes with longer axial lengths, at least in my European population, tend to have deeper ACs, but I don't know that that's necessarily true in patients of Asian descent. So it may be that they're longer eyes. It may be that they have steeper corneas that make them more refractively myopic, but they have a relatively smaller anterior chamber compared to the size of the eye, and that's really the predominant risk factor. All right, so the aqueous humor, we again said flows out through the trabecular meshwork, and this is just a diagram showing from the book showing that anatomy that I talked about: the uveal TM, the corneoscleral TM, and the juxtacanalicular, which is right next to Schlemm's canal, and then you've got Schlemm's canal, which is again endothelial line canal, outlets through the collector channels with pulsatile flow. My friend Murray John, really amazing demonstrations of this pulsatile aqueous flow, this dynamic aqueous flow. All right, so this is the aqueous outflow equation, and I'm always thinking about balancing this equation. So aqueous production is F, so the pressure, P is pressure in the eye, aqueous production is F. The pressure in the eye is the aqueous production minus the uveoscleral outflow divided by the outflow capacity plus the floor is the episcleral venous pressure. All right, so you could imagine you could turn F all the way down to 0, give them all the aqueous suppressants in the world, and drive this number into a negative number, and you're still not going to get much lower than the episcleral venous pressure. It basically is the floor. It's as low as we get, and in most patients, that's 6 to 8 millimeters of mercury. We do know that aqueous production varies throughout the day. It varies with age. It decreases with age. Ciliary perfusion is important, obviously, so patients with some vascular dysregulation, and we can give drugs that suppress the production of aqueous. The uveoscleral outflow is about 40% of the total. The outflow facility is one way of describing the trabecular meshwork function, and we talked about the floor there. So you have to understand that equation and sort of memorize that equation for the tests that you'll take, but it's a good way to sort of contextualize if you can keep what you're doing with the patient when you sort of turn the knobs to lower the pressure. So again, we know that intraocular pressure is the primary risk factor. Statistically normal, the 95% is up to 21, but the median tends to be higher than the mean, so more like 16 or 17. So it's not a normal distribution. 40 to 50% of people with glaucoma have a pressure in the normal range, and all treatments lower the intraocular pressure. Surgery, we think, may do a better job than medical treatment at decreasing the fluctuation of the IOP throughout the day. And there are some sleep lab studies that demonstrate this both with laser trabeculoplasty as well as intraocular. And then there's a whole bunch of stuff here in the table that you should review that can raise or decrease the intraocular pressure. So we measure the intraocular pressure with some device that presses on the eye and then gives us a measure of the force that comes back from the eye when we press on the eye. That's, in a nutshell, what we're doing with all of the things that we measure the pressure with. So, pressure equals force over the area, and the surface area, the cross-sectional area rather, of our Goldmann applanator is 3.06 millimeters square. And the little dial that we turn is calibrated such that one little dial can help us indicate the pressure. So each one you multiply by 10, right? So you can measure the pressure that way. If the applanation tip was a different size, we would need a different calibration on the dial, right? These are good Myers. This is a good measurement. They just come together like that. These Myers are too fat, probably too much fluorescein. These Myers are misaligned. So you're gonna get a number that's not procedure properly. And basically we're just pressing this biprism against the cornea until it flattens. And then what you're seeing in the Myers are the little tear film menisci there at the edge, and they line up because there's a prism in this. All right, so there's sources of error in tonometry. And again, it's something, if you don't do a lot of tonometry, it's something you really need to practice and get good at. You should be the best one at tonometry in your clinic, and you can teach your technicians and other staff to do it as well. So there are factors that can artificially lower the IOP. There are biomechanical factors of the cornea, corneal edema, especially acute corneal edema, cornea irregularity, high astigmatism, poorly calibrated or has been calibrated for a while tonometer, too little fluorescein in the tear film will result in an artificially low IOP, thin central cornea, technician errors. I mean, I guess it's sort of all of these things, right? And measurement done over a soft contact lens. And then factors that can artificially raise the IOP if they hold their breath or Valsalva. Nobody wears neckties to their eye appointments anymore, but they use the books. Again, a rigid cornea can result also in a high IOP, cornea irregularity or scarring, thick tear film, extraocular muscle force. So if you're pressing on the eye while you measure the IOP, it's probably not so that can raise the IOP. Astigmatism, poor calibration, obesity or straining. So that kind of goes in with the Valsalva, right? Pressure on the globe, squeezing the eyelids tight, thick central cornea, or the tight color tight. So all of those things. So you have to keep those in mind. There are other types of tonometers, including the McKay-Marg type tonometer. This is more for the tests that you have to understand or know these terms. But the TonoPen utilizes the McKay-Marg principle of a strain gauge in the center of an annular ring. It can be useful with corneal scars. And why is that? Because you can find the area of the cornea that doesn't have a scar. So if I'm using one of these other devices, so if I'm applanating, it's a normal cornea. If it's an abnormal cornea, then I'm using one of these other devices. And first, I'm looking at the eye to determine what part of the cornea is normal. And that's the part of the cornea that I'll applanate. So if there's a dense scar, there's no point in applanating over the dense scar, but you could use it, for example, to applanate or measure the pressure over the. So it's not just a assembly line. You have to think about how to get useful information. I use a Newman tonometer a lot in abnormal corneas. And a lot of what I like about the Newman tonometer is that I can measure at the sclera or the limbus with it and still get an accurate measurement. It's not exactly it does the same measurement as the central corneal intraocular, but it's consistent for patients who have a lot of corneal scarring. Maybe they've had 3 or 4 corneal transplants. They have any normal cornea anymore. And I have some patients with prosthetic devices, plastic corneas, basically. So I have to measure over the healthy part of the eye that has not been non-contact, like the air puff tonometers measure the force of air required to flatten the cornea. And one version of this non-contact can measure corneal hysteresis, which in the last couple of years has become very popular, and to stratify risk for both glaucoma and progression of glaucoma in our patients. And then the rebound tonometer uses a little piston that shoots out, bounces off the cornea, comes back into the shaft, generates a little voltage, and that's calibrated to the pressure. In the normal pressure range, the rebound tonometer is very good. As soon as the pressure starts to become really low, it doesn't really work, or really high, it will tell you that the pressure is high, but it's hard to know exactly how high. So all it is. And this appears to be strongly affected by this. So it's the normal range, let's say, 520 to 580. Good. Really thin cornea or really thin cornea. All right, and then the last thing to talk about with tonometry is infection control. This has obviously become an issue in the last 3 years with COVID and the worry about transmission, but HCV, adenovirus have all been measured in the tear film. The gold standard for sanitizing applanation tips, gold applanation tips, is dilute bleach. You have to be careful to make sure you rinse and dry the applanation tip before you use it on a cornea. Every time, or the bleach can cause an epitheliopathy. It generally will resolve after a day or so, but it's a hard thing to explain to your patient. Alcohol wipes can be used, but are not as effective at killing these things, and they can still be detected on the tip even after, just in lower quantities. So really the bleach is best. And then single-use tonometer tips are obviously a luxury if you can use them. I don't love. They introduce some additional air. The Myers aren't very good, but they're better than they used to be. Chapter 3 is a quickie. Clinical history, we've talked about a lot of these things already: age, ethnicity, family history, what kind of symptoms they may have. Intermittent angle closure, we talked about, has some symptoms of pain at times, visual disturbances like the rainbow halos around light. Pigment dispersion, these patients will often notice some blurring of their vision after they exercise. Or during exercise, and uveitis, sometimes photophobia, redness, irritation. If they've had any surgery before, any trauma in either eye, that's a standard question I ask. Seconds to get that history. Systemic disorders, asthma and COPD. These patients often have been on and off steroids. Migraine or vasospasm has been associated with normal tension, low tension, but sleep apnea. It's been associated with low tension, but also other types of glaucomas. Diabetes can cause, early cataracts and other medications. Cardiovascular disease, thyroid eye disease can elevate the the epithelial venous pressure. Medication use, of course, corticosteroids we care about because it can raise the risk of glaucoma. Mesh work. Beta blockers may make some of the medications we use less effective if we're using topical beta blockers. And drug allergies, because we don't want to give medications that they may have an allergy to. And then really serious review of the records. If I have records to review, I really take a few minutes and go through and make sure that I understand all the surgeries and procedures that a patient. All right, so what does a patient understand about their glaucoma is really important, because it's going to affect how they can understand you and the treatment course. So how is it affecting their functional activities? Do they consider themselves visually impaired? Do they think they're going blind? And do they need referral for low vision services? I often will ask the question, if you have a family history, did your mother who had glaucoma, did your mother lose her vision? Did your mother need surgery? Because that's the experience that the person has had, and it's going to really help you understand where they are when you're talking about surgery, if that's what they need. All right, and then chapter 4, we look for on physical exam. We obviously want to know what the refractive error is. We can't do perimetry if we don't know what the refractive error is. High myopia is associated with pigment dispersion and primary open angle glaucoma. It can confound to the point that was asked in the chat a little while ago, the evaluation of the optic nerve, head, and retinal nerve fiber layer. And often what I have to look for is progression over time rather than a snapshot in time, because it's just so hard to know from a snapshot in time. And then hyperopia has, of course, been associated with primary angle closure glaucoma and small optic nerve. We want to look at the outside of the eye, so look at the face and the eyelids for signs of other diseases like tuberous sclerosis in this first photograph here. which has been associated with vitreous hemorrhage, neovascularization, retinal detachment from tubers, these hematomas inside the eye. Juvenile xanthogranuloma can occur on the eyelid or on the surface of the eye. Oculodermal melanocytosis, also known as the nevus of Oda, can predispose to glaucoma, neurofibromatosis. You see the S-shaped eyelid deformity, and encephalotrigeminal angiomatosis, which is a big way of saying Serge-Weber, what we used to call Serge-Weber syndrome, leads to elevated intraocular. And then, other abnormalities that you may not be able to see, may or may not be able to see, that can affect the episcleral venous pressure, like orbital varix, arteriovenous fistula, SVC syndrome, and thyroid eye disease. So pupil function, really important. RAPD, relative apparent pupillary defect, can occur in highly asymmetric glaucoma. We have a lot of pseudoexfoliation here in Pittsburgh, so those patients very commonly will develop in RAPD. But most of the primary type glaucomas don't, because it's a more symmetric. But if you have an RAPD and it looks like symmetric glaucoma, then you got to look for some other reason. Does this person have, partial retinal detachment? Do they have some other optic neuropathy? Is there some other reason why they would have an RAPD, because the glaucoma doesn't look so asymmetric? So unfortunately, they come to me with other eye diseases, not just glaucoma. You want to look at the conjunctiva for signs of hyperemia and follicular conjunctivitis that might indicate an allergy to topical medications, scarring that might affect your ability to plan surgery for the patient, presence or absence of the bleb, and if the bleb is intact or leaky, as you see in this series of photographs, needs to be dealt with, because it's a risk for syndenophilitis if it's not managed appropriately. The episclera, you want to look for dilated episcleral vessels, like this sentinel vessel that suggests a ciliary body melanoma or ciliary body tumor. Thinning of the sclera or evidence of scleritis, and scleritis is usually uncomfortable for the patient, so as you examine them and touch around their eyelid, they'll wince. Otherwise, sometimes it's not that impressive if it's a diffuse scleritis. But of course, you can have then you're going to look at the cornea, and down here you see an example of hypostria. In congenital glaucoma, they're usually these oblique or horizontal strias compared to like force of injury stria, which tend to be more vertical. Tape erosions from medication use, microcystic epithelial edema from high IOP or medication use, and endothelial deposits from the disease itself or from the medication. And then we're going to look in the anterior chamber. Here you see an example of iris bombay in a patient with uveitis, plateau iris, malignant glaucoma. I don't have an example of. This is an example on the right of pigment dispersion syndrome. So you see this densely pigmented trabecular meshwork here and a concave peripheral iris. You always want to compare the two eyes when you're looking in the anterior chamber with or without gonioscopy, and you're looking for any kind of cell or debris in the eye. And then the iris, you can have heterochromia, ectropia, and here you see ectropia iridis associated with neovascular glaucoma, choroctopia associated with congenital abnormalities, nodules from inflammation or tumors, pseudoexfoliated material, presence or absence of veneerodectomy, NVI, there's fluorid NVI in this case, neovascularization of the iris, trauma, iridodenesis, so really floppy iris suggesting pseudoexfoliation, and irregular in contour or TIDs. So big TIDs associated with pigment dispersion syndrome. This is a really classic appearance of pseudoexfoliation. So you've got this sort of exfoliative looking lens capsule in the center, and then in the periphery and in between this clear zone of contact with the iris. This is a mature cataract with little white plaques associated with phacolytic or phacolysis. If the pressure is elevated, then we might call that phacolytic glaucoma. Here you've got little brownish plaques, brownish greenish plaques on an iris associated with siderosis of a retained metallic intraocular foreign body. And I didn't show a picture of a PSC cataract associated with corticosteroid use. And then, of course, in the back, you can have big choroidal effusions. That's what you see here, associated with hypotony or inflammation, hemorrhage in the vitreous or in the fundus, and inflammation. And gonioscopy, sort of my last selling point here, is underutilized, but really necessary for the correct diagnosis and management of glaucomas. Direct gonioscopy is most done in the OR, indirect at the slit lamp with a mirrored lens, either that contacts the sclera or the cornea. You have a mirrored lens that contacts just the cornea and allows dynamic gonioscopy for the assessment of apposition versus synechial angle closure, and that's what we refer to as a Zeiss style lens. And you see in the table some of the things you can find on gonioscopy. So direct gonioscopy using a Kepi type lens allows you to overcome the total internal reflection of the cornea and the anterior chamber angle in order to look directly into the angle. We use this in the operating room all the time in microinvasive glaucoma surgery. And then indirect gonioscopy uses a mirror, and this is what we more commonly do. And with indirect gonioscopy, you can press and open the angle. So if you press on the cornea, it deepens the central chamber. Gonioscopy, we want to use ideally a dim room with minimal light beam, especially if the patient has narrow angles or narrow appearing angles. So often I'll do gonioscopy in sort of a little bit more light. And if it looks like the angles are a little narrow, then I'll really dim the lights and look to see if they could be appositional. You can use this parallel pipette to identify the position of Schwalbe line and help orient yourself if it's otherwise difficult. I usually start with the inferior angle, looking for variability. There are a variety of grading systems. Use something even simpler than this, but you should be consistent however you're describing the angle. Things you might see are blood in Schlemm's canal, here associated with elevated episcleral venous pressure or sometimes hypotony. Neovascularization of the angle, there's one here with angle closure, peripheral anterior synechia. So here you see a sort of broadish PAS from previous inflammation. So here you have a widened angle recessed angle in A, inflammatory precipitates. And then in this case, you see the classic Sampol-Lacey line here on the black line compared with the trabecular in the two. And this is associated with uveitis as well as pseudoexfoliation, which we pretty commonly see here. And then trauma, again, we talked about, so this is a fairly recessed angle. You've got angle recession. You can have cyclodialysis. So this looks white because you're looking at the sclera where the entire ciliary muscle is torn away. Iridodialysis where you're looking through a hole in the iris, or you can have a trabecular cleft like this after the angle procedures we do after goniotomy procedures where you've incised in all the way to Schlemm's canal. Finally, I think anterior segment imaging, this is pretty quick. There are basically two flavors. There's UBM that uses sound and anterior segment OCT, which uses light. So UBM can penetrate through opaque structures like the iris to see the ciliary body, and the anterior segment OCT cannot. And that's the UBM is usually done in a supine position, and the anterior segment OCT is done sitting up. So things that move around in the eye might be affected by that positional change as well. And you can train almost anybody to do an anterior segment OCT because the machines, are pretty straightforward, but you really need a skilled UBM, and you have to ask specific questions with UBM. I want to look at the iris root at 5 o'clock in order to get specific answers. And I know I really appreciate everybody's patience because there was a lot there.
Dr. Connor, thank you so much. I tell the residents every single time, or mostly every single time, how blessed they are, because for the faculty, it is no joke to take the time that has been allotted to them, which is so short, and distill all those pearls of wisdom. Thank you so much for doing that for us today. Handing it over to Dr. Abeba to teach us chapters 5 through 7.
Okay. Thank you, Aisha, for the generous introduction. And also, I would like to thank HCP for involving me in this glaucoma classroom session. And I want also to say good morning, good evening, and good afternoon for all the participants, and happy holidays for the Ethiopian participants from Ethiopia, as today is our holiday, Epiphany. So, as it was mentioned, I'm going to address the 3 chapters in this given short period of time, and I will focus on the main areas, and I hope this will be a stimulant for further reading for all of us. So the chapters that I'm going to address are 5, 6, and 7. 5 is dealing with clinical evaluation and imaging of the posterior segment in glaucoma. Chapter 6 is on perimetry, and chapter 7 is a primary open-angle glaucomas. Coming to the clinical evaluation and imaging of the posterior segment, Glaucomatous damage involves loss of ganglion cells and their axons. And there is peripapillary change or atrophy. And within the optic nerve head, there is a change within the lamina cribrosa, which is the weakest point, neuroretinal rim loss, enlargement and deepening of cupping, and vasculature changes. And there is also neurodegeneration from the optic nerve to the lateral geniculate nucleuses and also to the occipital cortex. Clinical examination of the optic nerve head using the slit lamp and lenses like 60, 70, or 90 diopters. This is the standard one because it provides high magnification and stereoscopic view, and it enables objective assessment of the optic nerve diameter, and also enables to do detailed evaluation of the back of the eye. The other clinical examination means is using direct ophthalmoscope, but subtle changes could be missed because of insufficient stereoscopic detail view. And the other one is indirect ophthalmoscope. This can be used for young children and for patients unable to cooperate with the slit lamp, but cupping and pallor may appear less pronounced, and it's also inadequate for detection of subtle and or localized changes. The structures that should be evaluated with the slit lamp and the lenses to detect glaucomatous changes are the peri-retinal nerve fiber layer, which is around the peripapillary area, peripapillary atrophy, particularly the beta zone, disc hemorrhage, neuroretinal rim for thinning, notching, or break, cup enlargement, presence of asymmetry, and disc vasculatures, either nasalization, bearing of circumlinear vessels, and the lamina cribrosa, whether it's round, oval, or slit, because it has meaning with the stage of glaucoma. Retinal nerve fiber layer is best visualized with the red-free, which is a green one. And it appears the fibers appears as fine striations, as you can see here in this picture, and it is easily visible superiorly and inferiorly in healthy eyes, but it's less visible in advanced glaucoma because of diffuse nerve fiber loss or thinness. So here we have some examples. Here we have a disc hemorrhage and also rim loss here in the temporal position, and also there is parapapillary atrophy. In this disc, there is lamina cribrosa striation, which is usually seen in very advanced glaucoma cases. And here we have peripapillary atrophy, which is commonly seen in advanced glaucoma. So after doing the clinical examination, we need to, we should document, careful documentation should include careful drawing and detailed description on patient's chart, and it's essential for diagnosis and detection of progress. Then coming to imaging of the optic nerve head, macula, and retinal nerve fiber layer. Subtle changes can be easily overlooked with the clinical evaluation and visual field tests, and assessment of the optic nerve head at the slit lamp or with photograph is subjective and shows relatively large inter-observer as well as inter-observer variation. So imaging, is a quantitative imaging, provides an objective, reproducible, and high-resolution images of the ocular structure relevant to glaucoma. And available normative database allow to determine the probability of the observed measurements are within normal range. And it's also helpful for diagnosis and detection of rate of progressive structural damage. And the spectral domain OCT is the most widely used imaging nowadays. OCT provides quantitative measurements of the peripapillary retinal nerve fiber layer thickness, optic nerve head topography, macular thickness, and also provides quantitative assessments of the microcirculation in the optic nerve head, peripapillary region, and the macular area. Retinal nerve fiber layer is measured around a circle of 3.5 millimeter from the disc, and the report includes the global average peripapillary retinal nerve fiber thickness and the average thickness in each quadrant. And the accurate measurement for diagnosis are the average peripapillary retinal nerve fiber thickness and the thickness in the superior and the inferior quadrants. So the topographic measurements of the optic nerve head includes mainly the optic disc area, neuroretinal rim area, and the cap disc ratio. The border of the optic disc is defined by the determination of the Brooks membrane or its opening, which is called BMO, and BMO and minimum rim width defined as a minimum distance from the BMO to the inner aspect of the neuroretinal rim. And this parameter is used for measuring the neuroretinal rim thickness, as you can see here. And the studies have suggested that this parameter may be sensitive for diagnosing glaucoma. Macular evaluation for glaucomatous damage, the macular area assessment is useful because the macular ganglion cells layer contains more than 50% of the entire retinal cells, and glaucomatous damage affects the area in the early disease process that can be undetected with visual field test or clinically, and OCT enables the quantitative assessment of the thickness of the macula. And the ganglion cell complex is a commonly used parameter to measure the macular thickness, and it is the thickness of the ganglion cell layer combined with the inner plexiform layer. So diagnosing ability of ganglion cell complex is similar to peripapillary retinal nerve fiber layer thickness or defect measurement, and it's better in myope eye as there is peripapillary degenerative change for measurement of retinal nerve fiber layer. So here we have an example of macular ganglion cell complex measurement. This is the map. So in summary, stereoscopic detailed fundoscopic evaluation with descriptive drawing, either documentation, is important in glaucoma evaluation clinically, and OCT provides quantitative, objective, and reproducible values of the ocular structures. So coming to the next chapter, which is perimetry. It's a means to detect functional defect in glaucoma. White stimulus on white background, which is called white on white, is the gold standard test with the automated static perimetry. Two major roles of perimetries are identification and quantification of abnormalities in the visual field, and the longitudinal assessment to detect progress and measures rates of changes. The pattern of testing points in the visual field, the most common pattern are the central 24° to 30°, which usually represent as 24-2 and 30-2 in Humphrey visual field automated perimetry or analyzer, and 10-2 for cases with advanced field loss. And it's central 32°, which is measured with octopus perimetry. Test points with Humphrey field analyzer are 6° apart, and they are 6° above and below the horizontal line, and every 10 to 20° test point for 10-2. That's why we need to do the 10-2 in advanced cases. So why is the central area are tested in glaucoma? Because of the presence of high threshold variability in the peripheral region, and most of the glaucomatous defects occur in the central area. So coming to factors or artifacts affecting perimetry result, patient aspect, inattentiveness, fatigue, misunderstanding of the test, refractive error, presbyopia, lens rim, small pupil size, which reduces the amount of light entering the eye, eyelid lactosis, dermatochalasis, and the learning effect. Usually the first test is not reliable. And from perimetrist aspects, if there is improper instruction, mispositioning of the patient, and it also requires monitoring during the test time. So coming to print out visual field interpretation, we look at after just checking, the identification of the patient, then we look at the reliability indices, which include percentage of fixation loss, false positive, and false negative. And then the threshold sensitivity map. These are the reliability indices. And then we have the threshold sensitivity map, the grayscale, and the total deviation plot here, a deviation, which is a deviation from the average corrected normal sensitivity, and its total deviation probability map, which is a deviation that fall outside the static range of normal sensitivity. And then we have the pattern deviation, which indicates localized loss after correcting for the overall decrease in sensitivity, and its probability deviation map here. And finally, we have the global indices, which are commonly the mean deviation and the pattern standard deviation. The mean deviation it's the weighted average of the total deviation value. 0 means no deviation from the normal. More negative value means more advanced loss. The pattern standard deviation it's a summary index of localized field losses. And we have the glaucoma hemifield test, which compares the sensitivity at the corresponding areas in the superior and inferior hemisphere. As you can see, it's 1 to 1, 2 to 2, 3 to 3. So, and this is said to be powerful for identification of glaucomatous visual field defects. So coming to the pattern of visual field loss in glaucoma, visual field defect corresponds to the retinal area with the nerve fiber bundle defects, and the common names derived from their pattern in kinetic perimetry. In static perimetry, the grid pattern with the grid pattern test pointers, there is a lack of smooth contour, but the name derived from the kinetic perimetry. So coming to the types, there are the names: arcuate or BRM scotoma, nasal step, paracentral scotoma, altitudinal defect, generalized depression, and temporal wedge, which is a rare one. So here we have an example, arcuate or BRM scotoma here, corresponding to this defect, and the nasal step here, corresponding to this, the area of area defect in this location. And then we have the paracentral scotoma, as you can see here, and this is corresponding to this area. And we have the altitudinal defect, like it looks like a hemi defect. And then this Humphrey Visual Field Analyzer has a software which perform a guided progression analysis, and it does analysis of progressive visual field change or defect over a period of time. So here we have an example of 3 years. So you see progressive change, with, marking of the progressive change area. Okay. So in summary, visual field is used to detect and quantify functional loss in its progression, and we should be familiar with visual field interpretation and the common types of glaucoma defect, and we should know artifacts affecting the visual field result. So coming to the third chapter, which includes primary open-angle glaucoma, glaucoma suspect, ocular hypertension, and low-tension glaucoma. POAG, I think it was mentioned by the previous speaker, Dr. Kroner. POAG is defined as chronic, slowly progressive optic neuropathy, and its multifactorial disease process. The risk factors are elevated IOP, age, age is a risk for development as well as for progression. Risk, Blacks and Hispanics are more affected than Caucasians. Thin central corneal thickness, which gives low IOP reading, and it's also a risk for disease development as well as for progression. Family history of glaucoma and myopia. There are factors that contribute for susceptibility, and this includes low corneal hysteresis, low ocular perfusion pressure, low CSF pressure, ganglion or axonal metabolism abnormality, lamina cribrosa, extracellular matrix disorder. So coming to the clinical features of POAG, it is usually bilateral, but it can be asymmetric, and it is symptomatic when the central vision is involved. Otherwise, it's asymptomatic in most of the cases, as we all know. And the diagnosis is based on clinical assessment. So the main diagnostic examination or tests to detect this type of glaucoma includes IOP measurement, gonioscopic evaluation, fundus assessment for the areas that we have discussed, measuring central corneal thickness, visual field, and OCT assessment, in addition to the routine detailed ocular assessment or examination. POAG prognosis and treatment. The prognosis, most patients retain useful vision for life. And the cumulative risk for blindness in 10 years is 7.4% for unilateral cases and 3.4% for bilateral cases. But if there is visual field loss at time of diagnosis, the risk of blindness is high, meaning the glaucoma is in its advanced stage at the time of diagnosis. And treatment, it's similar to the other form of glaucoma: topical medication, laser treatment, and filtration surgery. Okay, coming to glaucoma suspect, the definition is patient who has one or more of the followings. One is suspicious optic nerve head or retinal nerve fiber layer appearance loss, appearance in the absence of visual field defect. Other is visual field defect suggestive of glaucoma in the absence of optic nerve head abnormality. Family history of glaucoma in a first degree relative, and elevated intraocular pressure without evidence of optic nerve head damage. So glaucoma suspect cases require periodic evaluation to detect any change or any progression to open angle glaucoma. Ocular hypertension, the definition is elevated IOP greater than 21 millimeter of mercury in the absence of optic nerve head damage, retinal nerve fiber layer defect, or visual field loss. And we should distinguish, distinguishing early POAG and ocular hypertension is often difficult. So we have to pay attention to the early sign of primary open angle glaucoma. And the signs are rim notching, cap asymmetry, disc hemorrhage, retinal nerve fiber loss, or visual field defect. So the point here is not to misdiagnose early POAG as ocular hypertension. And there is no clear consensus about treating ocular hypertension so far. The ocular hypertension treatment study has identified 4.4% treated versus 9.5% non-treated to develop glaucoma in 5 years. So we have to consider, risk factors for either treating or non-treating patients with ocular hypertension. And the risk factors that have been suggested by ocular hypertension treatment studies are old age, higher IOP, thin CCT, which is a biomarker for glaucoma susceptibility, large baseline cap to disc ratio, and higher pattern standard deviation on value on visual field. So treatment decision may be based on the ocular hypertension treatment study outcome, clinical evaluation and discussion with the patient. There is a risk calculation model based on data of the ocular hypertension treatment study and European glaucoma prevention study, which is available online. So coming to the low tension glaucoma, it's an open angle glaucoma without IOP elevation. And the cutoff between normal and abnormal intraocular pressure is arbitrary. And glaucoma can develop within the range of IOP level observed in the general population, meaning within the normal, with the IOP level, which is considered as normal level. So coming to the risk factor for low tension glaucoma, vascular factors like vasospastic problem, ischemic vascular diseases, systemic hypertension, and sleep apnea. And the clinical features of normal tension glaucoma, it's a bilateral disease, and worse damage can occur in the eye with relatively higher IOP. And this hemorrhage is common in this condition than in POAG. On visual field, the defects are usually focal, deeper, and closer to the fixation. The differential diagnosis in all types of optic neuropathies or primary open-angle glaucoma with IOP, diurnal IOP fluctuation, and patients on systemic medication like beta blockers, and patients with thin corneal thickness. Diagnostic evaluation is the same as other open-angle glaucomas, but we have to pay attention to systemic conditions. Treatment, what has been suggested is to lower the intraocular pressure by 30% from baseline. The collaborative normal tension glaucoma studies has indicated that visual field progression reduction from 35% to 12% in 5 years period of time with patients treated to lower the intraocular pressure by 30%. And the target IOP should be reassessed, even if it's reduced by 30%, it should be reassessed and adjusted as needed during the follow-up for each patient. So in summary, POAG has clear clinical features and risk factors that one has to know. And glaucoma suspect cases require no medication, but periodic evaluation. Be careful not to misdiagnose early POAG as ocular hypertension. And before diagnosing and treating low tension glaucoma, make all relevant evaluations. I thank you for your attention.
Dr. Abeba, thank you very much for that. This is amazing, and really happy holidays to all of our Ethiopia participants here today, and Dr. Abeba, especially on the holiday, to be with us. It means so much.
Thank you. So I just want to, if there could be a little bit of clarification on the clinical features, like the disc findings. I think if they can clarify for us, please. Beta zone, the papillary atrophy.
I have a confession to make. I don't get too excited about alpha versus beta zone. Maybe because I have the luxury of the ability to really follow my patients with fields and OCT. And that really tells me more than anything that's the progression over time. But peripapillary atrophy does confound the ability of those tests like the OCT to give us a good measurement of the RNFL. And when we see a lot of peripapillary atrophy, I just know this is maybe going to be a trickier than average case. I note it when there's peripapillary atrophy, and it's often my myopic patients who are a little bit tougher anyway to follow and diagnose.
We usually focus on the presence of peripapillary atrophy and its extent. Otherwise, we don't bother about whether to identify is it the beta or the alpha beta or the alpha zone. So what's said to be is related to glaucoma damage is the beta zone, which is related to ischemic damage of this peripapillary area. Otherwise, I don't think we should bother about which one to identify which one is the alpha zone or which one is the beta zone.
These are really great clinical pearls. I guess maybe on a test question, if they're asked it, Dr. Rooney, do you have any pearls on maybe on a test? How does that get asked, if anything?
Specifically about peripapillary atrophy, I think that I've seen one question at some point about differentiating which zone is what, but it's I think relatively low yield clinically. It may draw your attention to pay more attention to the cup to disc ratio in the absence of an OCT, and it may also just kind of be a tip off to someone who has high myopia and therefore has a risk of glaucomatous defects or frank open angle glaucoma. Someone did ask a question about, should we be refracting everyone who comes in for a glaucoma evaluation? And of course, I actually think, yes, that is useful. I'd love to hear the input from Dr. Khan or Dr. Abeba. But for me, I look for the higher myopia range patients as a risk factor for glaucoma, as well as the hyperopic patients for angle closure glaucoma.
Yeah, I mean, I also kind of feel like refraction is the low-hanging fruit for vision restoration for patients worldwide. So we have to be clear, right, that a pair of glasses is not necessarily solving all of the visual diseases that a person can have. It can really change a person's life in a pretty significant way, and probably buys a lot of trust for the physician then when you say, okay, well, we've made it so you can read and you can navigate better, but you also have this other problem that I can't fix with glasses.
Absolutely. I think that's such a pearl, right? I mean, yes, it's good to know myopia and the level of myopia as it relates to glaucoma, but don't forget that it's the bigger picture, right? We're talking about the full eye and about curing blindness. And when we're talking about that, refraction is your basic. So definitely be the best refractionist out there, because that's your basic to curing refractive error, which is one of the leading causes of blindness. Another question that has come up, and I'll hand this over to Dr. Abeba, and then we'll close. Why is there disc hemorrhage in primary open angle glaucoma?
Disc hemorrhage is it's common. It's said to be common in normal tension glaucoma because it is associated with vascular problem. But we can see such changes in primary open angle glaucoma cases as well. So it's related to vasculopathies around the disc area or on the disc area.
Thank you to all of the faculty, the residents. Next up, in 2 weeks from today, on February 2nd at 10:30 a.m. EST, Dr. Indira and Dr. Pratibha from Tilganga Institute of Ophthalmology. Thank you very much, one and all. We'll see you in 2 weeks.